Good morning, everyone. Sorry, we'll start from here. Good morning, everyone. Today, I'm going to talk on how to individualize treatment in mantle cell lymphoma. So, we will be talking about the current management of mantle cell lymphoma, a brief about the Indian data, whatever is available, and then we will discuss the individual scenarios in this rare disease. As we all know, mantle cell lymphoma is a fairly rare disease. It's about 7% of all non-Hodgkin's lymphomas data on the West. In India, it's about 3 to 5% of all non-Hodgkin's lymphoma, and there is a definite male preponderance. And the median age in the West is about 68 years, and whatever data we have from India, it's about a decade lower. Most of these patients present with advanced disease, with a significant proportion having involvement of the bone marrow, and about 15 to 20% have a peripheral blood spill. These symptoms are common. About one-third of patients have these symptoms, and the unique feature is the involvement of the gastrointestinal tract. The colonic involvement is seen in about 90% of patients with advanced disease. Central nervous system involvement is rare, less than 5% of patients. Diagnosis in the current day is fairly straightforward because of the extensive use of immunohistochemistry. The morphology itself can be variable, though traditionally it's been described as having small cleaved cells. The IHC is quite characteristic with co-expression of CD5, CD20, CD19, and the hallmark, of course, is the cyclin D1 positivity. And more recently, the recognition that SOX11 is an important marker for mantle cell lymphoma. Further confirmation by FISH demonstrating the 11-14 transmutation or by PCR. Now, based on the cell of origin, we have two types of mantle cell lymphoma. One is the classic type, which presents with lymph node involvement and extranodal involvement, usually of the GI tract, which is a much common variety, and it's usually SOX11 positive. The leukemic type, on the other hand, is slightly rarer, maybe 10-15% of the cases. Predominantly leukemic presentation, bone marrow involvement, spleen, very limited lymph node involvement, and classically this is SOX11 negative. Importance being that this second type, the leukemic presentation, has a more indolent course. Both these types can acquire genetic abnormalities. Classic type, usually the MYC, P53 can happen in either, but more common in the leukemic type, and then evolve or present with a more aggressive blastoid or pleomorphic mantle cell lymphoma, which is generally thought of as having a poorer prognosis. There are 5 published studies on mantle cell lymphoma, which I could get from my literature review. Consistently, all of them report a median age of about 57 years, and most of them report a significant proportion having bone marrow involvement, and again, 15 to 20, 30% of them having a peripheral blood involvement. Blastoid presentation is seen about 15% of the patients. The prognosis of mantle cell lymphoma, classically, we use something called the MIPI prognostic index, which has got 4 variables: age, ECOG, LDH, and the WBC count. Based on this, a scoring system is assigned, and you divide the mantle cell lymphoma into low risk, intermediate risk, and high risk. And this data actually comes from a slightly older German study, which was published in 2008, of 455 patients of mantle cell lymphoma from the German mantle cell lymphoma study group treated between 1996 and 2004. And based on the older study, the 5-year survival of the 3 groups was 60%, 35%, and 20%. More recent data in 2014 of 958 patients in the same group treated between 2004 and 2010 shows a significant improvement in survival, but still the prognostic categories are relevant. The low risk is a survival of 83%, intermediate risk is 63%, and the high risk is 34%. This is, of course, the advent of the rituximab, which has changed the prognosis in this era. Of course, other indices can also be used. FLIPI, IPI, all of these have been shown to be prognostic for mantle cell lymphoma also, mainly the use of age, LDH, and stage are significant. Again, biological factors like the Ki67, which indicates the aggressiveness of the disease, high serum free light chain ratio, and more recently, the expression of P53 have also been identified as prognostic factors in mantle cell lymphoma. If you look at current trials, the median survival is about 8 to 10 years, which is much better than what we see from the German data about a decade back. Having said that, again, I want to reiterate that prognosis is highly variable in mantle cell lymphoma, and even we very well know that based on the biology itself, two separate subtypes are recognized with two separate prognoses. With this background, let's move on to specific case scenarios where we need to individualize treatment. The first case that we will be discussing is a 60-year-old male who presents with a lymph node swelling, no B symptoms. He has small nodes in the neck and a few in the axilla, a splenomegaly. The counts are okayish except for the increase in WBC count. The bone marrow biopsy confirms the presence of mantle cell lymphoma. However, the SOX11 is negative and the K67 20% is low. PET-CT is done, which is the recommended staging investigation for mantle cell lymphoma, and shows a limited lymph nodes in cervical axillary region, uptake in the spleen and bone marrow. A subgroup of which can potentially be observed without immediate treatment. So this is one study which tried to look at it. This is data from the Weill Cornell Medical Center. Patients treated in the early part of 2000. They had 97 patients of mantle cell lymphoma. Out of this, 31 were observed without immediate treatment. Immediate treatment means treatment within the first 3 to 6 months of diagnosis. And 66 of them underwent initial early treatment. So those who were so-called observed, among those who were observed, 71% of them were observed for more than 6 months, 45% for more than 1 year, and 10%, that's a very small proportion, 3 of them, would actually be observed for more than 5 years without significant progression of the disease. What it shows is that we can have a small group of patients where you don't need initial immediate treatment and they still have a very good prognosis, but the challenge is to identify this. So, of course, these patients were identified based on clinical parameters. What is the difference between those who had early treatment and those who had observation? Typically, the observation group had earlier stage presentation, and the WHO performance status was 0, showing that most of them came with asymptomatic or minimally symptomatic disease. And the IPI was also on the lower side for these patients. Significantly, the MIPI scores were not different between those who were observed versus those who were given early treatment. What happened to the patients of those who had deferred treatment? Obviously, they had a much better survival. Obviously, they had a much more indolent and much more quieter disease. But the moment they needed treatment, from that point onwards, if you compare them and the early treatment, there was no difference. Once they require treatment, from that point onwards, the prognosis is similar. But till the time they require treatment, they seem to have a better prognosis. Again, the challenge here is to identify those who have early treatment and late treatment. It is, as I mentioned, not very easy. There are some pointers which you can look at. Unfortunately, the classical clinical parameters were unable to clearly pinpoint those who were those who could be observed versus those who required early treatment. The other pointers towards this is the Ki67. Again, this is a data which came out subsequently. And here you can see that those who have got a Ki67 of more than 30% have got only a 5-year survival of 41%. So this is a subgroup which you definitely don't want to recommend observation. We know that SOX11 overexpression defines a more aggressive subtype of mantle cell lymphoma. So if you have a SOX11 positive disease, again, you'd be very careful about recommending observation in that particular subgroup. Again, TP53, multiple studies have shown that independent of MIPI and K67 has got a poorer prognosis, more aggressive disease. So these are yet to be validated in clinical practice. So this is a subgroup where you can individualize your treatment and possibly think of close observation. That is a leukemic presentation, splenomegaly, low K67, SOX11 negative, few enlarged lymph node, and possibly, if you have access to that, P53 expression negative. Moving on to the second scenario, this is a 47-year-old male bank manager, presents with fever and B symptoms, the generalized lymphadenopathy. He has got a kind of low platelets and anemia. Peripheral blood is showing atypical lymphocytes. It's a classical mantle cell lymphoma, K67 on the higher side, 50 to 60%, and extensive disease on the PET scan. This is definite advanced mantle cell lymphoma. We are not going to discuss observation here, definitely requires treatment. It's a young patient. What are the options here? So there are 4 options here. One is BR or RCHOP. This data comes from the Still and the Bright trial. This is usually used for patients who are not fit for autologous transplantation because currently autologous transplant in CR1 is considered as standard of care for mantle cell lymphoma. This treatment as such would be considered as non-curative. However, as I said, more recent trials are showing that survival is getting pushed further and further. But traditionally, for a younger patient, we would like to do an autologous transplant, and the before transplant regimen of choice currently is a combination of R-CHOP and RDAP, and in a moment I'll show you why. So we continued with maintenance rituximab as per the data from the LYSA study. However, the role of maintenance rituximab after bendamustine-based induction is questionable. You have a median PFS of 7 years and overall survival extending beyond 10 years. And of course, when you add the DAP to the CHOP, you have a better survival. The third option is hypercvad alone, because most of this data comes from a single center. Hence, it's not very popular across the world. And I will show you some data that you don't have to really use hypercvad. It's definitely a much more toxic regimen. There was one randomized trial comparing Velcade instead of vincristine in CHOP, that is called the Velcade RCAP, which compared to R-CHOP, seemed to improve the PFS without changing in overall survival in mantle cell lymphoma. So between BR and R-CHOP, my current choice, as I think most centers in India would use BR. The reason for that is this data from the Still and Bright studies, both of them clearly showed the PFS is better when we use BR. Not only that, the toxicity is much lesser with BR as compared to R-CHOP, other than the skin rashes, which can be troublesome in a few patients, but most of them tolerate the bendamustine rituximab combination much better than the R-CHOP combination, especially when we are dealing with older people. So this is probably the regimen of choice in any patient with an aggressive mantle cell lymphoma whom you are not considering transplant upfront. The data for rituximab maintenance comes from the LYSA study, where the patient after autologous transplant would randomize between rituximab and observation for 3 years. And here clearly there was a superior EFS as well as overall survival with the addition of rituximab maintenance. This is a controversial area whether you still need to do maintenance rituximab after bendamustine rituximab. This is the maintain trial from Europe, and this trial actually did not show any difference in the PFS whether you use rituximab or not in patients who had responded to bendamustine rituximab. Similarly, there was no difference in the overall survival. Hence, the role of rituximab maintenance after bendamustine rituximab induction is questionable. However, there are people who still use it. There are experts who still recommend it, but currently the data does not support it. This is the data to show the effect of a mixed regimen of R-CHOP, RDAP compared to R-CHOP. This is the European Mantle Cell Lymphoma Network study, and clearly you can see there is an improvement in the time to treatment failure, 9 years versus 3 years, which is quite significant, and also in overall survival at 60% versus 12%. Of course, there's more toxicity with RDAP, but for a young fit patient, that should be the treatment of choice. Still think about or talk about hypercvad. There's only one randomized trial which tried to answer this question, comparing a regimen of R hypercvad to 6 BR as a pre-transplant induction regimen. Unfortunately, after 53 of the 160 planned patients were accrued, almost 1/3 of the patients in the R hypercvad arm had mobilization failure for the autologous transplant. Based on this, this trial was called off, and the interim analysis of whatever was recruited did not show any difference between these two regimens. So, based on this and other data from some other retrospective series, it is to be taken that there is no real need to push such a toxic regimen as hypercvad, except some centers where they are extremely comfortable and very used to using this toxic regimen. The third scenario, we just talk about an early stage Hodgkin's lymphoma. Here, an elderly gentleman comes with a lymph node mass, bilateral cervical lymph node, no other sites of disease, biopsy suggestive of mantle cell lymphoma. So we don't have randomized trial in this setting. Obviously, it's a rare presentation of mantle cell lymphoma to come with only stage 1 and stage 2 disease. But we have two important studies here. One is from the Nordic lymphoma group, where 43 patients with stage 1 and 2 mantle cell lymphoma were treated with radiation alone, and a 5-year overall survival of 93%. Another slightly larger study from 13 institutions, which were done as part of the International Lymphoma Radiation Oncology Group. And here again, we have an excellent survival. Whatever you use, there is no difference. And the 10-year freedom from progression may be slightly lower when you use radiation alone, but the overall survival is not different whether you use chemotherapy or chemoradiation. So we can safely say that radiation alone is a reasonable option for an elderly patient who presents with limited stage mantle cell lymphoma. There may be a recurrence, but you can treat at that time with chemotherapy or immunotherapy. Maybe for a younger patient, you may add radiation along with some chemoimmunotherapy, but generally the survival in this group is excellent. The last scenario is the relapsed mantle cell lymphoma. I'm not going to spend a lot of time here just to enumerate the options available for these patients. The current choice of a treatment based on a small series of data is, of course, ibrutinib, which has got a best response rate of 68%. More recent data seems to suggest that a combination of ibrutinib plus venetoclax has a response rate as high as 83%. So if somebody can access venetoclax, this probably would be a better choice than ibrutinib alone. For those who cannot access ibrutinib or venetoclax, what we have at this point of time is bortezomib and lenalidomide, both of whom have got modest activity in mantle cell lymphoma, and in the relapse setting can help prolong the survival for a few months or few years, depending on how the patients respond. Some interesting data on the use of palbociclib, because a cell cycle regulating drug, and as you know that cyclin D1 is activated in mantle cell lymphoma, driving the disease. So there is some data to suggest a combination of ibrutinib plus palbociclib can be quite effective in extensively pre-treated mantle cell lymphoma, but at this point we have only data from the phase 1 trial. Of course, CAR T cells, as in any other cancer, has leukemias or lymphomas shown excellent activity, but this is theoretical for us at this point. Needless to say, for patients who have a long gap between their first-line therapy with BR or R-CHOP, re-challenge with IV chemotherapy is an excellent option. So we have a response rate of 75% with BR in patients who relapse after R-CHOP, and patients who failed after BR may still respond to R-CHOP, but the exact response rates are not very well known. One more option which I have tried for some patients is if you have 3 or 4 years after BR and you relapse, then you can redo the BR, and some of them again get 1 or 2 years out of it. So you can mix and match all these things, and the disease keeps responding, and you can try keeping keep on prolonging the survival as much as possible. For a young patient who not yet had an autologous transplant, salvage followed by transplant is also an excellent. We cannot stop without talking about oral metformic therapy, an excellent option in patients with relapsed mantle cell lymphoma. The first paper came from Morton Coleman's group. It's called the Pepsi regimen, which is a continuous procarbazine, etoposide, prednisolone, cyclophosphamide regimen. Generally okay tolerated. You may have to tweak around the doses a bit to adjust to the tolerance of the patient, but they did demonstrate excellent response rates in mantle cell lymphoma at that point of time. Subsequently, another study where they combined the Pepsi with rituximab and thalidomide also showed an excellent response rate and good progression. So this is not something to be discarded. An excellent option in relapsed mantle cell lymphoma, and quite safe and easy to do for many of them. So these are the curves from the Pepsi regimen, and as you can see, the overall survival data looks quite good, and the PF is also quite reasonable. So when we just want to summarize the individual therapy in mantle cell lymphoma in India, first thing is the indolent disease may be safely observed, and we talked about how to recognize those who may have an indolent disease. For young fit patients, BR or R-CHOP, RDAP followed by autologous transplant with or without R maintenance seems to be the treatment of choice. This would be for majority of the patients who are young. For older people not fit for autologous transplant, only BR or R-CHOP followed by R maintenance. For relapsed disease, the preference at this point would be ibrutinib. If you cannot access ibrutinib, then bortezomib or lenalidomide are reasonable options, and not to forget metformic therapy as a very good option for mantle cell lymphoma. I'll stop with this slide. So an excellent database. These are guidelines. At this point, these are in draft form, but are available for access. So any of the students want to access treatment paradigms for most of the cancers, it's available from National Cancer Grid. Most of what I've talked about is available in this one slide. So you can also utilize this resource for understanding the treatment paradigms, and these have been tailored to what can be done in our country. So with that, I'll stop now, and thank you very much for patient listening.
Yes, good morning, everyone. I think this was an excellent talk, Dr. Prasanth. So thank you for this lucid and very informative talk. I have some questions for you for this discussion. Now, how would you, in the initial workup of any mantle cell lymphoma, how would you actually put an endoscopy, a CSF analysis upfront. Would you recommend it for all your patients with mantle cell lymphoma?
Thank you, Dr. Puneet. It's a very good question because, as we know, mantle cell lymphoma has got a very high incidence of GI involvement. So, residents often ask whether we should ask for a per GI endoscopy or a colonoscopy in these patients. But the reality is that we take it that the GI is involved. It doesn't change the management for most patients who've got stage 3 or stage 4 disease. So, unless a patient comes with early stage mantle cell lymphoma, which itself is a rarity, and you want to rule out a more advanced stage disease, so in that case, probably you would consider doing a endoscopy or a colonoscopy in a person with a otherwise stage 1 or 2 disease. And a stage 3 or 4 disease who does not have any GI symptoms, I would not really go and do a colonoscopy or a upper GI scopy. Regarding CSF analysis, I think the it's not very common to get CSF involvement in mantle cell lymphoma. It's about roughly about 5%. So if somebody has symptomatic, yes, definitely you would want to do a CSF analysis. Otherwise, there are some reports which suggest that a blastoid phenotype of mantle cell lymphoma has got a higher chance of CNS involvement. So if upfront somebody presents with a blastoid morphology, you may consider doing a CSF to rule out a CNS involvement.
Thank you, Dr. Prashant. Second question is on surveillance. How would you probably monitor the MRD in mantle cell lymphoma? I mean, do you even use PET as a surveillance technique for patients who have completed their therapy, and how would you use it as a MRD modality?
I don't use PET scan other than at baseline for staging and probably at end of therapy just to document the remission before they go for a transplant or something like that. I do not use PET scan as a surveillance modality as of now in mantle cell lymphoma. I don't know whether some trials are looking at this specifically as a early marker of relapse and something like that. I think in general, there is no data that a PET surveillance improves outcome. So at this point, I don't do any kind of imaging unless it's guided by symptoms during follow-up. It'll be just clinical follow-up, probably a CBC because it's mantle cell lymphoma.
Thank you. My third question is on, how are you placing rituximab in a situation where there is so much of COVID and in the era of COVID? So, how would you make any changes to your maintenance rituximab?
So I think we already during the talk we discussed that the role of maintenance rituximab is not very well defined in those who have already got bendamustine rituximab. So in those patients, definitely I don't want to go and do something of questionable benefit. In all the other patients, maintenance rituximab clearly shows an improvement in overall survival. And I think over the last couple of years, we have kind of understood that you don't want to deny life-saving therapies in cancer patients during this COVID time. So I would rather give the rituximab and take the chance rather than because mantle cell lymphoma is otherwise can be a deadly disease. So I would go ahead wherever it's indicated. I would go ahead giving the rituximab. I would not give it.
Thank you. If I have 2 more minutes, I can ask one more question. Sachin, is there more time?
Yes, sir, please.
Okay, so how would you identify patients who might be resistant to ibrutinib? So if you've supposedly started patients on ibrutinib based therapy, what are the telltale signs? Is there anything that can tell us, or is there any follow-up that we should be doing regularly to know whether there is resistance to ibrutinib in relapsed mantle cell lymphoma?
Let me confess that I have not used a lot of ibrutinib in mantle cell lymphoma context, so I don't have any clinical experience on that count. But I mean, from the trials, I think about 1/3 of patients with relapsed mantle cell lymphoma actually do not respond to. They have like primary resistance to ibrutinib. Are there any factors which can specifically tell us that this person is going to be resistant? I am not aware. I don't know whether Dr. Manju or Pause, they're on the call, whether you could ask them, or I don't know the answer.
Yeah. I think one last question: how would you put an allo transplant? Where would you like to put an allo transplant? When would you want to offer it? That's my last question.
Again, I must confess, I have not really done an allo transplant in a mantle cell lymphoma. Probably somebody with a blastoid morphology, maybe who has a tough time getting into a remission. Probably you need to use a couple of salvage therapies to push them into a remission, and that person, you expect them to relapse very fast after an auto. So maybe those kind of people, if you get a remission, maybe allo transplant may be an option to discuss with them if they are otherwise young, fit with a donor. That's my guess. I have not really planned an allo transplant in a mantle cell lymphoma.
Thank you, Dr. Prasanth. No more questions from our side.
Can I request Dr. Advani and Dr. Bharat Parikh if they have some questions? They're welcome to ask. Dr. Advani?
Yeah, I think I wanted to ask you apart why we are not using ibrutinib as an upfront treatment. And second thing is there any data about acalabrutinib in the mantle cell lymphoma?
So yes, sir. Thank you, sir. The first question, yes, there are currently trials which are trying to place ibrutinib in the first line in combination with chemotherapy and are also as part of some chemotherapy-free regimens. So the results of those trials are not yet out. Probably we're going to get them in the next couple of years. So then we will know whether it's really going to be useful to place the ibrutinib in the front line. It's probably going to come. It's probably going to come in the next 2-3 years. We will know the answer to that. Regarding acalabrutinib, yes, there is data for acalabrutinib also in the relapsed mantle cell lymphoma. At this point, it does seem, without a direct comparison, does seem that they are probably equivalent drugs with some differences in their toxicity profile. So I think both of them are reasonable options at this point of time for relapsed mantle cell lymphoma.
Thank you.
Thank you, everyone.